Hi, I'm Francesca Gomez.
And I'm Bryce Newberry.
Families across the United States have been impacted by the opioid epidemic. 116 people die every day from an opioid overdose. So even if you haven't been directly touched by this crisis, there's a good chance your friends or family have been.
Conservative estimates indicate that 2.1 million Americans fit the criteria for an opioid use disorder, but more recent studies indicate that number could be as high as 4 to 6 million. 2,500 people have died. Nearly 17,000 suspected overdoses have been reported. That's just in the last year and a half here in Arizona.
Medication-assisted treatment, or MAT, combines medication and behavioral therapies. It's effective in reducing illegal drug use, increasing treatment retention, and preventing fatalities.
We leveraged the power of ASU to access the experts on the front lines of this crisis to look for solutions. We're here with Claire McClune, and she's an instructor at Arizona State University's School of Social Work. She's also a volunteer at Shot in the Dark. It's Maricopa County's only syringe access program. Claire, we need to break down the difference between addiction and dependence.
So the big difference there is that dependence is actually one of the criteria that you need to meet for addiction. So I can be dependent on something and not necessarily be addicted to it. For example, coffee. I drink coffee every day. I'm definitely physically dependent on it. If I wanted to stop, I might get grouchy, I might get a headache. But because I'm not experiencing any negative consequences, don't have a strong desire to stop using coffee and not being able to, I don't meet criteria for addiction of coffee. One of the reasons why we get this idea of addiction being a moral failing comes from our history of how we treat addiction. Anyone who was addicted to a substance was basically shut away, pushed away, or incarcerated. So we're still treating addiction as if it's a choice when science tells us that it's not always that simple.
There's been a lot of conversation around whether or not it is a moral failing or a brain disease.
There's nothing about someone's character that can make them immune from addiction. Addiction is categorized as a brain disease. Maybe I have a predisposition for addiction because of trauma or something inherited, hereditary, and then things in my environment kind of make the disease progress faster.
Today we're talking about medication-assisted treatment, and what about encouraging abstinence?
Well, abstinence is an ideal choice, right? If we want to reduce the harms of drug use, obviously the safest thing to do is to not use drugs at all. But that's also similar to saying, driving in your car is dangerous, so just don't ever get in your car. We don't do that, right? We have seatbelts. We take precautions and measures to make sure the driver's safe. It's very similar with drug use. We don't know why somebody uses drugs, right? There are complex, complicated reasons that people use drugs, whether it be to treat trauma, to even sometimes to prevent suicidal feelings. Maybe somebody is medicating with a substance. And again, the defining feature of addiction when you cross that line from dependence or maybe substance use to addiction is when you desire to stop, but you can't. You start having all these negative consequences, and despite them, you continue to use a substance. And that's because of a physical change that happens in your brain. And that's why MAT is so important, because your brain takes time to heal, right? Those reward circuits have been dulled down. The things that I would regularly do that are healthy to get the feel-good chemicals going in my brain, like exercising or hugging someone even, like those release the same chemicals. Illicit drugs, illicit drugs, release those chemicals in a really high dose, really quickly all at once. So it kind of dulls the reward circuits so that now when I go exercise, hug someone, I'm not getting the same effect that a normal person would. To prevent the craving withdrawal process that keeps so many people from achieving any form of sobriety, that's where MAT, medication-assisted treatment, is really important, because it prevents that while your brain heals.
Claire, thank you so much for your time.
I'm here with Rick Christensen, a physician assistant and certified addiction specialist who's been prescribing medication-assisted treatment for over 42 years. Today, we're going to be discussing the different components of MAT. So Rick, you mentioned a couple different types of medication. How do you know which medication is right for who?
A carpenter was once asked, what's the most effective at building a house? a hammer, a saw, or a level. And he said they're all effective, but they're used for different things. It's not so clear with medication-assisted treatment. So we try and match the right medication to the right patient. But the basic tenet of medical ethics is patient autonomy, and what that means is, at the end of the day, the patient gets to choose what medication they take. The medical provider explains the risks and benefits of each one of the medications, pros and the cons, and then the patient gets to choose.
You mentioned that these medications help to actually normalize brain chemicals. So essentially that means that they help the patient focus on recovery and not the craving. What other FDA-approved medications are currently out there?
Well, there are only 3 medications that are currently approved to treat an opiate use disorder: methadone, buprenorphine, and naltrexone. But at the end of the day, it's really clear that you can't just do counseling and expect that people are going to get better, because their brains are fundamentally changed. And we know that based on brain scans, not based on frying pans and eggs. You know, the old commercial, "This is your brain on drugs." We know exactly what it looks like. We know exactly what the changes are, and we know exactly how the different medications interact with the opiate receptor to normalize that. People don't go to drug treatment to get high. They go to drug treatment to get well. They go to drug treatment to change their lives. We have very good studies that have looked at reaction times and cognition on methadone. And we found that you can't tell a difference between a patient who's on methadone or not. So a methadone patient can drive, they can do any job that any other normal person can do, because it doesn't cause sedation.
And Rick, do you want to go ahead and let us know how these medications are administered?
Sure. So a methadone is an oral medication. It's a liquid. It's typically mixed with cherry syrup, and it's taken orally in front of a nurse every day for the first 90 days of treatment. The most common use of buprenorphine is called Suboxone, and it's mixed with an opiate antagonist so that if you injected it, it would throw you into withdrawal. It comes in a strip form that you hold under your tongue. If it's being done not in a methadone clinic, it's being done by a private physician. They're getting a week prescription, so they're using that at home once a day, and once they're stable, they can get a monthly prescription. Naltrexone is an injection. It's given deep intramuscular.
And Rick, what would you say to people who say that these patients are just junkies?
Do we say that about patients with high blood pressure? They have to take their medicine every day. People with asthma, people with diabetes, they're taking medicine every day, and they're dependent on that medication. And what I would convince you of is this is a chronic, progressive, often fatal illness that's characterized by relapse, and it's medication that normalizes the brain so that they don't relapse. And so I abhor the term junkie. 60% of our female patients were sexually abused before the age of 15. 40% of our male patients were sexually or otherwise traumatized before the age of 15. 30% of our patients are homeless, yet these people dig down deep inside of themselves and they find reasons to get better, and I'm inspired by that. And so these are heroes. These are people that have overcome things that most people don't have to get through, and they succeed. They stop using, they make changes in their life, they go and get a degree, they get a good job. People find ways to get better, and as medical providers and counselors and family members, we need to dig down deep inside of ourselves and find reasons to help. I always tear up because I'm thinking of hundreds of thousands of people who have been so stigmatized in their lives, who still get better in spite of all of that.
Thank you so much. I'm here with Sarah Finmore, a policy coordinator at Sonoran Prevention Works. Sarah, thank you so much for being here today. Can you go ahead and give us a little bit of background on how you got started?
My background's in international relations, and I was studying drug trafficking in South America. I was living in DC, focusing on Colombia and Venezuela and the way drugs move, and then I was down in Chile, focusing on how cocaine moves between Peru and Bolivia and Chile. And the biggest thing I learned was that for as long as there is demand for drugs, there's going to be a supply. So the efforts we take to control supply push demand, they impact demand. We can't just cut off drugs and expect people to recover and not need them anymore. So after I had that realization, I came back here as the overdose crisis was just increasing exponentially. I was like, we need better policies. We need policies that focus on drugs as a health issue rather than a criminal issue. So that's how I came to SNOR and prevention works.
Sarah, can you go ahead and explain to us what harm reduction is?
The easiest way to understand it is meeting someone where they're at. It's accepting that drug use happens, it's a reality, and to find avenues to recovery, there's a lot of different ways to do that. There's not a one-size-fits-all, because sometimes people aren't able or aren't willing or don't have the resources or support they need to go into recovery, to be completely sober. So what do we do for those people? We need to meet them where they're at and find out how to make positive changes. Harm reduction recognizes that drug use exists on a continuum. There's significantly more risk for some drugs than others. So when we recognize those differences, we also recognize what behavior changes may need to happen to decrease these negative consequences, whether they be HIV, Hep C, overdose. All of these are preventable, but we need to meet people where they're at in order to prevent them. We need to be thinking about how a one-size-fits-all approach doesn't work. So while someone is using, there are still positive changes that they can make to reduce the harm to themselves. So when we just assume that someone's not worthy of health support or resources or compassion unless they're completely sober, we are missing a huge group of people that need help.
Why are you so passionate about this?
These are regular people who are just trying to get well. We need to be thinking about the overdose epidemic as big as it is, because we all have someone in our lives, family, friends, people in our community, people that we work with who use drugs. It is so important to me that we do not forget their stories or forget their humanity because of their drug use. They're not separate things. You are still a human if you are using drugs, if you are using substances. So why would we deny you a health service so that you can take care of yourself? Why would we do that? That it's incompassionate and makes no sense, especially when we're thinking about the community impact it has. So let's meet them where they're at. And let's understand where this is coming from as well. It's not a personal choice. This decision comes from a need. And there are a lot of different needs, whether that be chronic pain, trauma, whatever it may be. We have to look aside from that and recognize where the root cause is.
I'm here with Dr. Sarah Solik, the Chief Medical Officer of Access, Arizona's Medicaid agency. Dr. Solik has worked with both youth and adolescents in a clinical setting, and now she serves in a public policy role. Dr. Solik is here today to help us understand how we got to this point, as well as what the public should know about prescription opioids. Dr. Solik?
Unfortunately, it was the convergence of multiple factors, including the pharmaceutical industry promoting their product and minimizing the risk associated with the use of their products, practitioner prescribing of opioids to all chronic pain conditions. Additionally, the public's request for a pain remedy that was effective, and the healthcare industry's monitoring of pain as the fifth vital sign. There's also an inflooding of the illicit market with illicit opioids.
So what's the risk of prescription opioids?
Physical dependence on the substance, so needing more of the substance in order to have the desired effect. It could also have withdrawal symptoms, so if you don't have the drug, you can experience flu-like symptoms.
So how can, for instance, my body tell the difference between prescribed opioids or illicit opioids?
Your body can't tell the difference between a prescribed versus an illicit. Opioid, it all boils down to the dosage. Just to put things into perspective, fentanyl is 50 to 100 times more potent than morphine is. And so your brain is responding to the dose of the opioid. It doesn't matter whether or not it was gotten from the streets or gotten from your provider. What we're seeing is this epidemic of fentanyl overdoses based on the potency, and nearly 4 Arizonans a day are dying based on overdose.
The pharmaceutical companies, they pushed opioids with false informations, and now we're looking for a pharmaceutical solution with MAT. Why should we, the public, trust the pharmaceutical companies now?
From my perspective, the way that we can rebuild that trust is by acknowledging that opioids do have those major risks. There needs to be those checks and balances where those researchers that are researching the product, that there's a separation between that and those that are actually publishing and reviewing the results, where there's not a conflict of interest, including peer-reviewed journal articles as well as meta-analysis through Cochrane to tell us what is the science, what is the data telling us. And so with that, what the data is telling us is medication-assisted treatment. That's an FDA medication to treat opioid use disorder in combination with psychosocial interventions such as therapy, peer support, that is the most effective intervention to assist an individual in recovery, both retaining that individual in treatment as well as a decrease in illicit substance use.
Well, thank you, Dr. Solig, for being so candid. We appreciate it.
Thank you for addressing this critical public health crisis.
We're here now with Carissa Riggs. She's a nurse practitioner at Community Medical Services here in Arizona. Carissa, some people might say you're just replacing one drug with another.
When you're using illicit street drugs, you're not guaranteed the potency of what you're using, and you're basically chasing your highs and your lows. So you use, you feel good, and then you start feeling crappy and you have to go use again. When you're on medication-assisted treatment, you're on a stable dose of medication. And once we find that stable dose, you're stable for 24 hours. You're not chasing those highs and those lows. And you're also being monitored by a medical provider to ensure that you're not having any side effects of the medication, and we adjust the dose as required in order to help you reach that stable 24-hour dose. We are not treating pain, we are treating addiction. Once we reach stability, then it's time to focus on the coping skills. Like when they are under a stressful situation, they need to learn how to cope with that as opposed to be numb to the situation. There's a big mental component, and I explain that to my patients, that that's where the focus has to be for you to be successful.
It seems like a lot of effort and a lot of maybe prodding at times.
Addiction is a brain disease. So it's no different than somebody having high blood pressure or having diabetes. They are treated by providers with medication to help them be stable and lead good lives. This could be your sister, this could be your brother, this could be your mother, your uncle. And how would you want them to be handled? Like, how would you want them to be cared for in that situation?
What impact do you think MAT can or will have? Do you think it could cure the epidemic?
I would like to say one day, yes, that would be the hope. But I think that for now, hope is what we have to hold on to.
Should we start with a tour?
Yeah.
Let's do
Okay. Patients come in through the door. The first thing they do is go check in right here at the front desk. So if they have to give like a UA sample or see a counselor or see a medical provider, they'll be told right there and then. If they're just receiving their medication, then they'll be put in the queue, and so they'll meet with a nurse to receive their dose of medication.
How many people do you see a day coming?
Approximately 500 a day. They're no longer having withdrawal symptoms. So that's why you see so many coming in, because they do feel better.
Yeah, I mean, the way methadone works in your brain is it actually stabilizes your brain chemistry. So when somebody stops using heroin, their brain chemistry stops producing endorphins on its own. And so you can replace those missing endorphins with a medication like methadone or Suboxone, and so it stops the withdrawal. So in the first 90 days in treatment, you're allowed one take-home dose, and that's on Saturdays.
But is there concern about diversion?
Typically not. We do diversion checks all the time too. So if a patient does have take-home privileges, like even the patients that have 28-day take-home privileges, we'll call them back randomly throughout the month and have them bring their bottle in, because the bottles are actually sealed. And so they'll have to bring in the supply that they have left. And if they've used more than they should have, then that means they're not using their medication as intended. If somebody wants to divert methadone or an opioid, this is the hardest way to get access to it. To actually qualify for the diagnosis opioid use disorder, there's a number of criteria that have to be met. You have to have been using for a certain amount of time or had gone through detox a couple times. And once those criteria are met, then you would be able to receive treatment from us. So medications such as methadone, Suboxone, or Vivitrol in conjunction with the psychosocial therapy. The research is starting to show that about 3 years in treatment is the amount of time it takes. So when you actually look at brain scans of people who are suffering from opioid use disorder, you'll see that at the 2-year mark, their brains are still starting to stabilize from the heavy opioid use. And so that's why we put somebody through detox that has an opioid use disorder through like a 28-day abstinence-based residential treatment program is not going to phase them, because their brain's going to be healing for the next 2 years. And so the medication really helps their brain stabilize so that they can deal with the psychosocial components that might be the root cause of their addiction. So that's why we do the therapy in conjunction with the medication.
You talked about the need because of such an epidemic. What are you doing right now to address the need?
So, it's ironic. Even if the need wasn't growing, the epidemic is growing, if that makes sense, because the need's always been there. I mean, for the last couple of years, there's a large amount of people in this country who are not getting treatment, but are not even acknowledging that they need treatment. So 95.5% of active drug users don't acknowledge that they need help. The issue of identifying, engaging people who need to get into treatments, right? That concept right there is something that we actually don't talk a lot about. What do you say to somebody to get them to get into treatments? You know, I lost a sister to a heroin overdose, and I ask that question all the time, like, what could I have done? I mean, we did like interventions and stuff like that, but you'll see, I mean, you hear people say, I hit rock bottom over and over and over and over and over again. I overdosed 3 or 4 times before getting into treatment. So it's not necessarily hitting rock bottom that gives people that aha moment. And so how do you engage those people to get into treatment? Well, that's what we need to figure out. And so if you could get clinics closer to the people in need, then you're gonna break down more and more of the barriers that are stopping them from getting into treatment. So the easier we could make it for people to get access to treatments, the more people are going to get into treatment, because addiction is a disease that's constantly telling people not to get into treatment, you know. And so we need to provide all means necessary to break down any of the barriers in their mind and that's stopping them to from getting into treatment. I mean, we opened the first 24/7 clinic like this in the country back in October, and we've intaked 4,000 patients in the first year. And we did that because, you know, we like to think of it as this moment of hope. That's what we call it, where somebody might make a decision at 3 a.m. to get into treatment, and if you don't get them into treatment right then and there, an hour later they might change their mind. So we do open at 4:30 in the morning, our clinics, so people could get their medications prior to going to work. And the research actually shows, in our clinics, our own internal research shows that employment rates increase by about 78% at the 6-month mark when people enter treatment. And so when we opened the 24/7 clinic, I think AZ Republic covered the clinic and interviewed a patient, and she entered treatment, and she had been on heroin for like 4 years. And entered treatments. 2 weeks later, she came in and she said, I got reunited with my kids that were taken away from me, and I have 2 jobs. Like 2 weeks into treatment. When you bring in medication-assisted treatment into environment, overdose death rates decrease by 75%. They've actually looked at entire countries like China, pre-MAT and post-MAT, and seen the same thing: 75% decrease in overdose death rates when you bring in medication. So we do the research on where there's high rates of overdose death rates, and we open clinics in those neighborhoods. Even here in Mesa, when we tried to open, it took us a while to get this facility. We had on this street here, we had a multitude of landlords that wouldn't rent to us, sellers that wouldn't sell to us. We went to get a conditional use permit on a piece of property, and they called us the night before and said, don't even come, don't bother showing up because we've had so much opposition to your treatment program. And I remember talking to one guy, and he said, I've had my building broken into like 5 times in the last week by drug addicts, and they're leaving needles. This is right up the street from here. And I'm like, so what do you want to do about that? Do you want to stick your head in the sand and think it's just problem's gonna go away? Do you want to have more police presence to arrest them? Do you want to, let's think about pragmatic solutions here. What are you gonna do? Bringing a treatment center is what's going to treat the patients. Why wouldn't you be more welcoming of that?
So just right here in this neighborhood, it was a problem.
Oh yeah, it's a problem. It's a problem in many, many, many neighborhoods. These are, would you talk about your sons or daughters like you talk about our patients? Because at some point, we're all going to be impacted, if we haven't been already, by an addiction in our immediate circle of friends or family. And so these are our fellow Americans, fellow human beings, whatever perspective you want to look at it from. I don't understand not helping people that are in need. I think if we approach addiction from a place of compassion, we're going to have more success. And I think everybody's starting to realize that.
We're here today with Dr. Luke Peterson, a doctor at Banner University Medical Center Phoenix Addiction Recovery Center. Dr. Peterson, can you go ahead and walk me through the process of an expecting mother coming in here looking to get some sort of treatment for her opioid addiction?
First of all, it's a really courageous and really difficult thing to do, to ask for help during pregnancy. Expecting mothers who have a substance use history or a opioid use disorder are marginalized. When a mom comes in to see me, the first thing I do is I just welcome her here because it takes so much courage to ask for help. The second thing is we find out what the mom's history is. What are they currently using? Mm-hmm. Does she have a home? We ask about the history of other mental illnesses and other medical conditions. We offer a gamut of blood testing for bloodborne pathogens, especially if someone is using intravenously. And then we talk about the treatment options, which for opioid use disorder include medication-assisted treatment, so medications in conjunction with behavioral treatments.
Now, what would you say to a mother who comes in and says, Dr. Peterson, I'm scared. I'm scared to get on MAT.
I would like to find out why she's scared. What is it about being on buprenorphine or methadone that is making her worried? We find that lots of times people are nervous that being on methadone or buprenorphine is a black mark for the Department of Child Safety. And so we reassure these moms that this is not a black mark. Being on these medications is part of the treatment, and that you can have a healthy pregnancy, and that you can have a healthy baby, and you can parent your baby when you're on these medications.
Okay, and why can't they just go cold turkey? Why can't they just quit?
So recommend not going cold turkey, not doing a, quote, detox, because the rates of return to use are so high, and we worry about the withdrawal that happens from cold turkey causing pregnancy complications. So when mothers are actively using, there's periods of time where they're using and there's periods of times when they're in withdrawal. And that cycle back between use and withdrawal, that does have clinical impact on the pregnancy. We see smaller babies, we see more complications with the pregnancy itself, to the point that you don't actually have lower rates of NAS in moms who do go cold turkey because of the high rates of returning to use. When we stabilize moms on buprenorphine or methadone during their pregnancy, those complication rates dramatically decrease, such that they can have a very healthy pregnancy as opposed to having some of these other side effects.
So for a patient who wants to come to this office and seek treatment, what's the process like?
There's really no wrong door to enter into our clinic. You can go to the hospital, you can go to the OB floor, you can go to your OB's office and get a referral here. You can see your primary care physician and get a referral. You can cold call our office and get an appointment as well. Opioid use disorder and other substance use disorders are chronic illnesses. They don't go away with pregnancy. They can oftentimes we manage them, but these are things that ought to be managed long term. And so what we often see is that after the baby is delivered and life is changing and things are stressful, there is a significant return to use after pregnancy. And for a long time, we have been really focused on like the baby when the baby's in the body, but we can't stop when the baby's delivered, because whatever effect that substance use has on pregnancy it pales into comparison to the effect that a using mother or father has on a developing child. And so we need to focus on the pregnancy, but we need to extend that longitudinally and follow these moms and these parents long term.
So, doctor, can you take us a little bit behind the stigma of MAT?
So probably the top stigma is, doctor, aren't you just changing one drug for another?
Right.
And I guess included in that is you can't be sober on MAT. And when I am talking to patients and also other clinicians and community members about this, the question that we need to answer is, what is addiction? Physiologic dependence is not in and of itself an addiction. Just like if I removed somebody's blood pressure medications, their blood pressures would rebound. They're not addicted to their blood pressure medications, and yet it is okay for them to be on it, even though they're physiologically dependent on it. My question then to people is, why is it not okay for you to be on MAT and be physiologically dependent on it, but like resolving all these other maladaptive behaviors and things that are going on in their life? And so in the strict definition of addiction, you could be on MAT and not addicted to it. So that being said, you can have a patient on medication-assisted treatment, either buprenorphine or methadone, that we now see those addictive behaviors go away. And they're actually doing what I would say are behaviors of recovery. They're parenting, they're goal-oriented, they're taking the medications as prescribed, they're not having any maladaptive behaviors, they're not using the medicines in a compulsory way, they're not craving, they're not continuing the medicines despite negative consequences, and they're not addicted, or they don't have an opioid use disorder despite being on an opioid. We're seeing behaviors of recovery. Yeah, there's a medication in their system that if you remove it, they'll go through withdrawal. There's physiologic dependence still, but physiologic dependence is not in and of itself an addiction. I would say that methadone and buprenorphine will, more than anything else, help moms to reach their goal of a healthy pregnancy, a healthy baby, and parenting their kid.
That was great. Thank you so much for being so thorough, doctor. Battalion Chief, why do you think it's so important for friends and family of drug users to have naloxone on them?
For anybody who's had allergies like an EpiPen, it's the same type of concept there.
So the EpiPen is essentially for people experiencing like anaphylactic shock,
Correct.
Whereas naloxone is for those experiencing opioid overdose.
Correct. That is correct. Having those things is a reactionary type of a situation. That means somebody's already overdosed and we're preventing any further compromise, even death, to those individuals. Personally, I think the focus is in the prevention side of things. We can relate it to drownings. There's a lot of things we can do, and that's where we focus, preventing those from happening. Now, teaching CPR on the back end and potentially saving a life once they've drowned, that's good to do, but let's prevent it from happening in the first place. With the crisis we have, I'm in the business of saving lives, so anything that does that, I'm in favor of.
So who is trained to administer naloxone? Do friends and family of drug users have to attend a training, or do they kind of just get it at the pharmacy?
Really 3 different types of administrations. There's a nasal version. That's simple. You stick it in a nostril in one of the nares and you inject, and it atomizes into the nose. So that one's really easy. That's the one that's available in the pharmacies. The instructions are there. I think that's fairly self-explanatory. The auto-injectables, that's another way that the public can get a hold of those. I believe the prescription is not with the auto-injectable, so there's a different format to getting those. Some of the auto-injectable devices have voices on them and tell you what to do. There's a lot of different technology out there with them.
What's it like for somebody to give naloxone?
We have the ability to give somebody the nasal version, the intramuscular version, or we can start an IV and give it through a vein, so intravenously. Intravenously is obviously the quickest. And when you give that to somebody that isn't breathing or almost not breathing, it is fairly impressive to see how quickly you start to see these effects take, they start to go into effect, and there's a reversal of what the opioids does, and they come back, and quickly they're sitting up. And oftentimes it's amazing to hear them say, "What did you do that for? Why did you push Narcan?" Some of them know the word, they know right away. "Did you give me Narcan?" And for some, it's a relapse after a long time of being clean, and it's a tough time. There's a lot of other things being put in the streets. We know that opioids that are sold outside of pharmacies, street drugs, there's dangers associated with that. We know this is a ladder drug. This is something that scales folks into heroin. Those things are being laced with fentanyl today. We are seeing a trend of having to give more Narcan, more doses. Whereas typically before, perhaps just a single dose would take care of the problem. We're having to rebolus some of those doses nowadays because of the insane strength of some of the stuff out there.
So we hear that opioid users can use naloxone. What about a regular person like me? If you were to hit me with naloxone right now, would I be okay? Would it harm me in any way?
Well, I certainly wouldn't be a proponent of giving Narcan to somebody who's doesn't show the signs and symptoms. There's a reason we give it. But it is safe. There's nothing that it would affect you right now. There's nothing that your body couldn't handle if we gave you Narcan. People do not need to be worried about overdosing them on Narcan, anything like that. It is a safe drug, and I think that's a lot of the reason why you're going to see this, or we are seeing this, come to the general public.
What's the cost for somebody to walk into the pharmacy and get naloxone?
The other day I called the Walgreens just here in the state of Arizona just to see if potentially everything is what I'm hearing, and the pharmacist did confirm that he has a script that he can sell under that prescription Narcan to somebody in the community. We didn't get into costs. There are programs to where you can get it for free of charge.
It's just so interesting because you think of naloxone as only firefighters carrying it. You don't typically think of the general public.
Yeah, and we can look at that on different fronts. Our police department here and many police departments across the nation have expanded, and all of our police officers carry Narcan.
Walk me through the process. What's it like giving naloxone, and what happens right after you give it?
The last one that I can remember was in a driveway where a son living at home with mom and dad was unconscious, found by mom, and we got there and followed our unconscious protocol, checked blood sugar. If that's normal, we give Narcan, and this was one of those cases where immediately Narcan took effect, and we knew what we had on our hands, and the individual woke up and asked those questions. Did you just give me Narcan? Why did you do that? And it's unfortunate that we have to explain to them. They almost don't understand that they were dying. They would have died left untreated. It is a lifesaver when used in those instances where there's an opioid overdose. It is absolutely a lifesaver. The only thing I would add is to encourage the general public to look for those warning signs. This doesn't happen overnight. There is a trend. Find ways to identify on the front side these things that are happening.
Battalion Chief Jason White, thank you so much for being here.
Okay, absolutely.
I started using drugs when I was in high school. When I got into college, I started using heavier drugs like cocaine. Eventually started working towards opiates, and I had a girlfriend that introduced me to heroin.
Why is it so hard to stop?
Well, part of it is a physical dependence because if you don't have them and you're physically dependent on it, you're going to become ill. They call it dope sick, and it's really is like this horrible flu that you have. And this psychological idea of, if I'm sick, I have to go to the doctor and go to the pharmacy, and then I'm going to feel better in a few days. Whereas if I'm dope sick, then I can go to my friend's house down the street or a mile or two away, and I'm going to feel better within a few minutes. It's a really hard kind of psychological thing to overcome. So I came to Tucson. My ex had come out here to try to get clean, to live with her dad and to try to get clean. And I followed a few months later because she brought my kid out with her. And we started using right away. I was still using, and she had cleaned up, but we started using. We moved in together and started using, and a couple months later, our kid was taken back to Illinois, which is where I come from, and I can remember waking up and thinking, I'm going to be 80 years old, and I'm still going to be chasing this high every day.
When and what made you decide to get help?
I think I was already at the point where I didn't want to use anymore. But that was really kind of like the final impetus. I was ready to not use anymore. And so I went to my doctor one day and I said, I'd like to start. So I finally started the Methadone program here in Tucson. I was actually a client here at CMS. And at that time it was a very small clinic. It was probably 100 clients or so. It was a private pay only. I signed up and just started the program. I still used for a couple months after that. But it was less and less every week, and then on July 18th of 2009, I used heroin for the last time. I had been on the program since about mid-May, so I'd been on it for about 2 months.
You remember the exact date, July 18th, 2009, that you stopped using heroin?
It's a week after my birthday, but I guess in a way it's my second birthday, so.
For people who are maybe thinking about MAT or in the process of MAT treatment, what would you say?
I would say trust the program, trust yourself, know that you can do it, know that it is possible to live a life without drugs.
As we've learned, the opioid epidemic is as vast as it is complicated. But thanks to the candidness of our experts, we were able to learn about medication-assisted treatment and how it helps to reduce the stigma and actually helps individuals to recover. The opioid epidemic is impacting people you know. But by uniting together, we can each increase access to care and help more Arizonans recover.
Combating this epidemic won't happen until we address the stigma. You can help by simply sharing what you've learned. With more education and awareness, we can make a difference in Arizona.